Good morning or good afternoon, depending on your time zone. My name is Bruce Kusan. I'm the Clinical Education Manager for Christie Medical, and I'd like to welcome you to our second webinar on vascular access issues. We have a distinguished panel of presenters, and I'd like to begin the program by introducing our two speakers. But first, I want to let you know that throughout the presentations, all attendees' phones will be on mute. We will be recording the presentation for later viewing. At the end of the presentations, we will be taking questions which can be sent to us by typing your question into the chat section on your webinar screen as shown. To collect your contact hour, go to the website or listed, and that will allow you to print your continuing education credit. Thank you again for your participation in this exciting webinar. Our first presenter is Dr. Gregory Shears. Dr. Shears is a pediatric intensivist and anesthesiologist with a long-standing interest in reducing patient complications and improving our approach to vascular access. He did his pediatric residency at St. Louis Children's Hospital, his anesthesia residency, pediatric anesthesia fellowship, and pediatric critical care fellowship, all at Johns Hopkins. He worked at the Children's Hospital of Philadelphia for 5 years and was recruited to the Mayo Clinic in 2001 to head the ECMO service. There he is the physician liaison to the nurse-led PIC team, medical director of the ECMO service, and co-director of the congenital heart unit. He is on the editorial board for JAVA and serves on the AVA board of directors as treasurer and recently chaired AVA's strategic planning task force. He is very active with product development to help reduce complications and has given hundreds of presentations locally, regionally, nationally, and internationally. Our second presenter today is Melissa Whitehead. Melissa holds her BSN degree along with many vascular access certifications. She has been a pediatric nurse for over 30 years and is currently the manager of the clinical resource team at Children's Medical Center Dallas. Melissa was integral in the development of the vascular access team at Children's Health. She is actively involved in various vascular access professional organizations. She has presented at these organizations and has participated in many roundtable discussions related to pediatric vascular access. She is a contributing author for best practice guidelines in the care and maintenance of pediatric central venous catheter for the Association of Vascular Access. And now I'd like to turn the program over to Dr. Shears.
Okay, let's see if we can move this forward. Okay, there we are. So, hi everyone, and thanks so much for joining us today for this webinar. This is an exciting time for me in particular because we're talking about a topic that I have found very important. Actually, this topic is one of those that really sunk the hook for me in terms of my interest for vascular access. And I'm going to explain what I mean by that in just a few minutes with a couple slides around that. So for my part of this, a necessary combination for best practice is an overall theme, and again, you'll see why that is shortly. So from a disclosure standpoint, I need to say that I'm a consultant for Christie Medical, maker of one of the near-infrared devices. Any non-referenced slides are based on my experience and opinion, and I'm a complete believer in the use of near-infrared as an adjunct for peripheral vascular access. So I think any of us involved in vascular access realize that we have a lot of problems, a lot of opportunities to improve patient care. And one significant problem that really is a barrier for us getting to the next level is the fact that we fail to prospectively manage our patients' vascular access needs. This is a stumbling block that is kind of at the beginning of the process. It is an absolute necessity to get to where we need to go. If we are not going to do adequate pre-access assessments, all of the rest falls apart to some degree. So this is a must. I want to convince you as part of this process, if you are not engaged in some form of pre-access assessment, to do so. And I'm going to suggest some things over the course of this presentation to maybe help make that process easier, because part of the barrier has been there's not been a good way to do it, to be quite honest. So the result of not doing proper pre-access assessment results in poor planning. And our patients end up suffering. They suffer because we're providing multiple sticks, and multiple sticks means unnecessary pain and suffering. And as a consequence, it should be no surprise to anybody that, Press-Ganey scores and other assessments of patient satisfaction have been really poor. And one of the themes that rings true constantly is that there is big patient dissatisfaction related to IV access and phlebotomy. And these are things we can do something about. We have the technology, we have the knowledge. We have not been dedicated to apply it in a broad way. And again, this is part of the reason for this conversation. So as a consequence of not doing things optimally, we are creating more and more difficult vascular access patients. I would say, or at least what I am seeing, is at epidemic levels. And so we are just spinning. We are creating more and more problems, which leads to further problems and further access challenges. We've got to break this cycle. And another thing that we are not doing adequately is we are completely underutilizing vascular access teams. They are the backbone of this process. We need to not disassemble. We need to assemble. We need to support. We need to develop adequate value propositions so the C-suite people get this. Vascular access teams are central to good modern patient care. And so it is critical that we look at strategies to use them, deploy them properly, have them used as consultants to help with this pre-access assessment and creating an appropriate plan for patient care. As we fail to deploy this pre-access assessment stuff, we are just adding to the overall healthcare costs and to complications. Again, we need to stop this. If we can just get a hold of this upfront component, we can help bring down costs and reduce complications through better and more efficient healthcare management. So I apologize for any puns that I throw out here. People that know me know I'm a bad punster. So if 2 wrongs don't make a right, what do 10 rights make? Well, they make vascular access best practice. I was trying to think thematically about a bunch of different things that I've been exposed to recently. And I came up with, or at least this concept sort of fell upon me based on predecessors who have used similar concepts in different ways. And I'll tell you what I mean by that. But interestingly, right 10, or 10 right, makes a lot of sense. And I'm gonna go over a few details about that and how that fits into this overall scheme. If you want the entire vascular access episode to go well, you need these 10 components like a checklist. So, just like we have been chipping away at the whole CLABSI thing and using our checklist and using insertional best practice and other things to really improve care, and we've made some definite success here, we need to get our hands around the entire vascular access episode from pre-assessment to line removal. And interestingly, as I thought about this, there's 10 main components that make up this process. And if we're going to have an ideal process, we need to get all 10 right. I think we could build a program around this, get it right, get 10 right. We need to have the right line, the right patient, the right clinician, do it at the right time, put it in the right site, use the right technique for insertion, have the tip position right, have the right securement, the right maintenance, and lastly, the right duration and removing that line when we need to. Now, we absolutely cannot get 10 right without pre-access assessment. Again, this is a stumbling block for us. It is a critical first step to make the entire process of getting it right work. So, part of, as I thought a lot about this presentation to try to deliver something interesting and meaningful, and I was talking to Mike Brazunas, and Mike is going to be presenting up at AVA in New York City about a pre-access assessment and some other things, particularly related to increased use of midlines. And his company, has this promotional scheme of right patient, right time, right line. And I kind of like that. I like to be right. We all like to be right. We like to do the right things. And so I think, in the back of my mind, that's one of the things that sort of made sense to me. And then our friend Nancy Moreau, who doesn't love Nancy Moreau? She's such a great educator, and she's got this wonderful program on vessel health and preservation, and it's titled Right Line, Right Patient, Right Time, similar kind of theme. And then, I came across this article in the British Journal of Nursing, Right Line, Right Patient, Right Time. This was published back in 2013. So again, same kind of idea. People are thinking about the time, patient, and line. What I'm suggesting is we need to broaden it to all 10 components that are critical for a proper vascular access episode for our patients. And again, people that know me realize I love medical history. I love the origin of things. And as I was going back through some of the literature, I found this article, which was really quite a good article, Stepping Beyond the 5 Rights of Administering Drugs. And, this is a basic tenet of nursing. And I'm sure that subsequent individuals, as they were developing their right type of approach, probably either purposely or maybe just subliminally thought about the right drug, right time, right amount, in the right way, and the right patient as something that helps that they may have learned in the past, which makes perfect sense and applies in other situations in the future. Notice that this article was published back in 1962. I'm guessing that most of the people listening to this webinar weren't even born then, let alone practicing. So Thora Kron is a very interesting author as well. I think she must have thought that this is such a basic thing she didn't even need to reference it, because she has absolutely no references in her article, despite the fact she's a well-known author and has published several books in the nursing literature. So what do we need, again, for an ideal vascular access encounter? Well, we have to provide a pre-access assessment. We need to take the patient history, understand thoroughly what the intended therapy goals are, examine the patient, consider what are reasonable vascular access options. Then we need to educate and partner with our patient. They need to buy into this. They need to understand what is possible, what we have to offer. And then we, as a healthcare community and as vascular access specialists, need to get the vascular access best practice 10 right. If we do that, the patient, with a high probability, is going to have an uncomplicated course. And that is the kind of success that we want. Nobody believed that we could get down to 0 with regard to CLABSI. We're doing it all the time, or we're really, really low. I know we can do this. I know that we can apply these 10 we can do our best with regard to best practice, get all 10 right, and significantly reduce our current level of complications and issues. And if we do that, everyone is satisfied. Clinicians are going to have a significant professional satisfaction, and more importantly, our patients are going to be satisfied. That is what we're about, and that's what we have to do. Okay, so how the heck are we going to do that? Well, people have thought a lot about, you know, the algorithmic side of things. So this is an algorithm that I pulled off the Stanford website, and I suspect that Nadine Nakazawa and others contributed to constructing this. And if you look at these algorithms, a very common thing begins with IV axis, what is the duration, and then what sort of vascular integrity or ease of access do they have. And so, you know, that I think ends up being a stumbling block for many people, because how the heck do you assess that? It's just kind of do we just approach it and just all have different definitions and just kind of go with what we think? Well, that's part of the dilemma we're in. We don't have a means of communicating this intellectually, and if we can't communicate intellectually about this, we can't drive research, and we can't standardize. Here's another axis algorithm. Nancy, I talked to Nancy Moreau earlier in the week, and she was so kind to send a more recent version of hers. And I like this one a little bit more. It's a little bit more straightforward, and it speaks directly, as you can see by the swirling oval, of good vascular integrity versus poor, how it's important to make that distinction, and how that distinction impacts your decision making. So it's critical. It's up front. You know, there's other issues, obviously, that weigh into your decision making, including the overall duration, what you're going to give, and the type of, you know, the osmolarity and whether it's a vesicant, all of those things, which we all know well. So all of those things drive the direction we take regarding our device choice. But at the beginning of this, again, we get back to how do we make an assessment of that vascular access integrity? How do we communicate that? Where do we draw those lines? And that, I'm going to address that in just a second. And so for a little history, from my own history, this is an article that got me excited about the academic side of vascular access. So I've been interested in vascular access and the challenges thereof ever since my pediatric residency back in the 80s. And I read this article by Amy Barton, not to be confused with our own Amy Bardin, who, of course, everybody knows as a wonderful person. This is Amy Barton. She's a very accomplished PhD nurse who's at the University of Colorado Health Science Center, who's a researcher, manager, etc. And this is an awesome article. I recommend anybody interested in vascular access to go back to read this. It's a quality improvement project which really had a significant impact and was the first thing that I found with regard to this access algorithm, and really got me excited about this concept almost 20 years ago. So here it is. This is the vascular access planning algorithm that they put out. And notice, very consistent with these others, that they talk about vascular integrity, good or poor, and how that leads into decision making. So they knew very well back then about these issues, and you know, this was a building block for our current thought process. And they actually had several phases to this project, which was started out as kind of a CQI project. And as they implemented this algorithm, even back then, almost 20 years ago, as a result of this CQI project, they reported in their results the need for fewer IVs, less difficulty starting them, and less stress. I'm not sure how they quantified that. They also reported significantly less time required for central line placement, and remarkably, even back then when people weren't paying that much attention to this, patients had significantly shorter lengths of stays. So, I mean, that's gold. That's immediate healthcare savings there if we can bring down length of stays. So very important. They showed it way back then, almost 20 years ago, and we can do that now with better practice. So going forward, this is a very rich topic. There's so many things. I'm like a kid in a candy store. There's so many cool things to talk about, but I need to focus the conversation on peripheral vascular access assessment. And so these are my objectives, to outline the critical importance of pre-access assessment prior to IV placement, to discuss the use of near-infrared as a screening tool, and to present a method for communicating this pre-access assessment. I've got to pick up the pace a little bit. The slowness of this advancement is doing a little bit of slowing me up just a little bit. So what must we do to solve this problem? So I'm going to talk about only two of the must-dos. We need to better define the problem, and we need to provide a practical screening tool. There's many more things that I hope to address in another presentation sometime. So defining the problem. So there's no standard method of screening that we have, no standard means of quantifying the difficulty of access or the limited veins that are present. We need to take advantage of modern technology and practices, and above all, we need a scoring system to allow us to communicate our findings, to put something tangible in the medical record, and to encourage better research in this area. So I'm going to propose a practical screening tool. So what do you need for an ideal tool for peripheral vascular access assessment? It's got to be easy to apply, make clinical sense, use current technology, provide meaningful categorization, allow our current algorithms to be better refined, that this tool could be validated and relevant to modern practice, and promotes research and continued quality improvement. So if you think about it, as you're going up to assess somebody visually, you put on a tourniquet and have a look. It takes some period of time, but with your eyes, you can look pretty quickly. This video isn't playing very fast, unfortunately, but believe me, it was very fluid and quick, and it allowed, just as you would look at a patient with a tourniquet on, you could see the couple veins in this young, otherwise healthy individual's hands, but didn't really have any other access. So a couple good targets, but nothing else beyond that. So you can do that quickly. Now, this one is almost humorous. I'm not going to let you watch the whole thing because it's just painfully tedious. As I'm trying to palpate all the areas, I mean, it takes a long time, it's clumsy, it looks goofy, and it's really not an effective way to assess a patient, nor I couldn't remember from area to area where I found veins, so it's just impractical. Similarly, using ultrasound either in individual pointed areas, or throughout the arm. Here you see me trying to do a multi-point assessment using ultrasound as a pre-assessment tool. And if this were playing normally, again, it's humorous because I'm touching down, looking, touching down, looking, touching down, looking, and it's crazy. It's not practical. You can't really do it in a meaningful way. Yes, I use an ultrasound every day with difficult vascular access for deeper veins, but as a screening tool, it just doesn't work. Here, again, I'm not going to really have time to play this out well. This arm practically was dipped in ultrasound gel. It is just shining from all of the goo. I mean, how impractical and messy that is. But that's the sort of thing you would need if you were really going to try to completely assess somebody's peripheral vascular access using ultrasound in a screening way. So now you take out your near-infrared device, it's as fast as you can see. I'm doing this quite slowly, actually, so you don't get motion sick as I'm moving it on the video screen. But as fast as you can wave the device, you get information about what are your vascular access options. It's awesome. I mean, it is made for this purpose, and I bet that we could deploy this in a meaningful way in order as an aid for pre-access assessment. So here's my suggestion. To build a screening tool that meets those criteria of easy to use and other things, probably we should build it not based on historic information such as, the DIVA score, the Kenyan. I mean, there's value to that in predictability, but patients vary from time to time with different circumstances. So we need to kind of assess them, all patients at a point in time, at that encounter. And so if we do it based on our means of assessment, where we have assessment through sight, assessment through palpation, assessment through near-infrared, the use of ultrasound, or no access at all. So patients will naturally fall out in terms of their vascular difficulty. So what I mean by that, so for example, a patient like a bodybuilder with no body fat would be a V category. You can easily locate all kinds of accessible veins by sight. And I'll build this out a little bit more. Or you may have somebody that maybe their veins aren't so easily easily seen, but through palpation you could find them. Thirdly, a patient, in terms of their difficulty level, might not be able to be visualized, might not be able to be palpated, but you get out near infrared and you can easily locate them. So this scheme allows you to categorize a patient's level of difficulty based on these three different screening methods. As I said, the visualization part, that's easy. We do that every day. The palpation part, applying that easily, not so easy. Near-infrared, extremely easy. And then we get into level of difficulty, categorizing a patient as ultrasound only level of difficulty, or they don't fall into any of the first four categories and they lack adequate peripheral veins, and they'll end up being, IO or central access for their approach. One could add additional quantification and qualification to this screening tool, if you will. One could categorize the level of difficulty or the level of veins that a patient has as either A, greater than 10 optimal choices, B, 5 to 10 optimal choices, or C, 1 to 5 optimal choices. And then you could further qualify their clinical condition as being a patient with renal failure, exposed to chronic steroids, have sight limitations due to amputation, mastectomy, other things. Maybe historically they have a profoundly limited dwell time for other reasons, or a pediatric patient, which brings in their own implications, or a geriatric patient, again, because of their poor subcutaneous integrity, brings in other implications, and of course the qualifier of bilaterality or left or right sidedness. All of these together could be used as a means of describing a patient's level of difficulty, and so following our pre-access assessment, we could actually apply this tool to quantify these patients, to describe them. And under these qualified categories, you could have subqualifications, the level of renal failure, etc. In pediatrics, their weight or their age could be additional qualifiers. So here's an example of a patient who's a difficult access patient who by visualization has no veins, and by palpation really has no veins. And so as we move forward then and we use near-infrared, we can see some veins. Not a lot, but there are some veins that are potentially good areas of vascular access. So how do we describe this patient to our colleagues or in the medical record? So, and I'm using the abbreviations here. So with our pre-assessment, visualization, from a visualization standpoint, V, By sight, bilaterally, no veins. By palpation or T, touch, bilaterally, no veins. With near-infrared, bilaterally, this patient is category B, 5 to 10 options per side for vascular access. So how ultimately we as a community decide, if we just then describe that patient as an NBB, since they, rather than, saying 0 for the other ones, because that's our best category for them, or if we decide to say all 3 categories because it describes the entire process relating to peripheral vascular access, is up to the future to describe. But I throw this out there as a potential, practical, easy way for us to get our hands around describing these patients. And so again, I hope this slide goes forward. Not moving. Try again. Again, something happened there. Okay, always fun with technical issues. I was a holdout with converting from a slide deck to computers, and I had this really fancy slide deck thing that went into a seizure mode and started firing slides constantly. That was the time at which I finally transitioned from standard slides to computers, realizing that the hazard of computers was clearly less. Well, this is a little annoying. I'm not advancing anything here. There we go. So I'm going to go forward on this one for the sake of time. And I'm going to pull out that animation. So it's very important to realize that the first 3 categories, the veins assessed by sight, the veins assessed by palpation, and those accessible through near-infrared, all benefit from the use of near-infrared. I want to just touch on that very briefly here. First, I want to, again, mention that while why pre-access assessment is so incredibly important, this is what it's going to do for us. It will allow proper prospective management. It will help us to standardize documentation. If we do pre-access assessment and we adopt some scheme, maybe like I'm proposing here, to help us describe our patients, standardize the documentation, improve clinician communication, and help promote research and quality improvement. And this will also help support the incredible value of vascular access teams, which will ultimately lead to improved patient care, increased patient satisfaction, and enhance efficiencies and reduce cost. So added benefits of near-infrared, beyond what I've already described, include things such as being able to identify vein patency. Whether you can readily see the vein with your eyes or not, you can very quickly and easily identify where the valves are. So here's just one example. If you milk the vein, you can get a sense of what the venous flow is like and exactly where the valve is. Hence, you can avoid it while you're doing your catheterization, and you can place your catheter tip in an optimal position. I think in the future, just like now we're paying attention to making sure our central catheter tips are at the SVC-RA junction to optimize drug mixing and other things, I bet in the future we're paying more attention to this with peripheral vascular access and the amount of flow in the vessels that we're putting these catheters. Near-infrared helps us with that assessment. The next video, if it'll come up, is again the advantage of valve identification in this patient. And if this will run, again, by milking the vein, because of the very rapid projection of the near-infrared onto the skin, you can see exactly the blood flowing and where the valve is right here. Next slide. And with identifying where the valves are, you can pick that optimal site for cannulation. I don't know if you can see my pointer, superimposed on the video. But you see this very nice straight vein. You see the valve here. You've got a great place to put your catheter tip somewhere well short of the valve, 0.5 to 1 centimeter short of that, making sure that it's in this nice straight area. And by doing so, likely, you're going to be much less prone to a catheter complication. So moving forward on my slides, last and certainly not least, the use of near-infrared for difficult vascular access. It's an incredible aid for that purpose, and certainly in my practice helps me out every day with these very challenging patients. So I'm moving on now as I'm coming to a close. I'm going to get on my soapbox. Okay, so we are, as a healthcare community, burning up a critical resource. That is the peripheral vascular system. We are using up veins like, we don't care about the future, and that's absolutely the wrong thing. We must get our hands around this as a community. We must do pre-access assessment and try to consider veins as a valuable resource. Humans, we have a weakness. We want to use resources. We are doing it to the planet constantly. You look around you, there's endless examples. The deforestation in the Amazon in Brazil, 1975 to the present, and the global impact of that. The alterations of the water supply throughout many areas of the United States. So we need to think of the venous system as a valuable resource. We must protect it. We must be patient advocates. And the other soapbox issue I'm going to circle back around is the quest for vascular access best practice. We must, as a group, constantly strive for that. So I ask you, join the fight and get 10 right. And that relates back to that clipboard of the 10 critical must-get-right items in order to have an event-free vascular access episode for our patients. So with that, in summary, pre-access assessment is key to best practice. Near-infrared significantly will help with the screening process. Practically speaking, there's no other way to do it. I've thought about this a lot. I just don't see how else to do it. It's ideal for pre-access assessment, and it provides added problem-solving capability, which I think, with regard to peripheral vascular access, you're going to find quite enticing in terms of the benefits it will provide you and your patients. Near-infrared will help take peripheral vascular access to the new level it needs to go. So please, save the veins and get 10 right. Thank you very much. Melissa, I'm going to turn it over to you as I breeze through my some of the references that I used for this presentation.
So I'm waiting to see if the slides will advance. Sorry for the delay.
Okay, Melissa, you should have control. You can advance your slides.
It's not advancing.
Melissa, can you page down on your screen? Page down should advance the slides.
I'm paging down and paging over, and it's not doing anything.
Okay, we'll do it from here. Sorry.
Okay. Yay! Well, thank you, Bruce, for the introduction earlier, and Dr. Shears for your great presentation on the importance of pre-access assessment incorporating the use of imaging technology. My slides aren't advancing. There we go. I have no financial relationships to disclose. The objectives for my portion of this webinar is to identify key factors for difficult access, describe alternative devices for vein visualization, and to discuss the importance in the use of vein visualization devices. I will be focusing on the right line, the right person, and the right technology for better patient outcome. Whoop, need to go back. There we go. Establishing vascular access is one of the most common procedures in the hospital setting. Vascular access is consistently one of the most distressing aspects of hospital admission for children and adults. Some of the challenges for pediatric patients are small veins, limited access points due to the size and the presence of baby fat, and managing the anxiety of children and their families. The adult population has their own set of challenges, but have many of the same challenges as the pediatric population. Our IV team places approximately 1,100 IVs per month. The team has a 90% success rate with an average stick rate of 1.3. Our IV team places approximately 1/3 of the IVs in our organization. Vein preservation is a priority for our patients. The first step is determining the right line. Perfect. We have utilized this algorithm for many years, and it is part of our standard of care. In order to determine the right line, we need to assess the estimated time of therapy and what will be infusing. The algorithm is similar to the ones Dr. Shears presented just a minute ago. It is important to consider an alternative access early if patient has known difficult access, vesicant infusion, or greater than 5 days of antibiotic therapy. We very rarely use midlines in our pediatric population, but this device should be considered for adults. There we go. Once peripheral IV access is determined, a pre-insertion assessment will need to be completed. Patients who are likely to be challenging for PIV access can often be identified by certain patient-related risk factors. I have listed the main factors to consider: the patient's age, such as less than 3 years old, or the elderly, size of the patient with a body weight of less than 5 kilos, or the obese, patient conditions such as peripheral edema, hypothermia, dehydration, septic shock, vasoconstriction, vascular access history such as a complex medical problem or long-term IV therapy for chronic condition, diagnosis such as sickle cell anemia, cystic fibrosis, cardiac, renal, diabetes, oncology, the GI population which have Crohn's, short gut requiring long-term IV nutrition. Other factors to consider is the type of infusate medications to be given and the skin color. When preparing for this webinar, I looked for different tools and algorithms for determining difficult access and any plan or process when difficult access has been identified. I had difficulty like Dr. Shears did. The scoring tool I found, as well as the one we use, were developed for pediatric patients, and I didn't find any published pre-assessment tools for adults. Next slide. The Difficult Intravenous Access Score, referred to as the DIVA, was studied and developed in 2008 by Yen, Riegert, and Gorelick. Their objective was to develop a tool to predict difficult IV access in children. This tool looks at age, vein visibility, vein palpability, and gestational age. This tool was developed to determine success rate for IV placement in children and adolescents in the ER. They found that patients with a difficult IV access score of 4 or greater were more than 50% likely to have failed IV cannulation on the first attempt. Next slide. This is the tool we use here at Children's Medical Center Dallas. We have utilized this tool for about 9 years. This tool is used to determine the patient's level of access difficulty and the appropriate personnel needed to obtain vascular access. This tool is completed on every patient prior to starting a PIV, and the score is documented in the electronic medical record. This tool assesses some of the same factors as the DIVA tool, but includes anticipated duration of IV, patient and parent cooperation, and the patient's history. We are currently in the process of reworking this tool. With the advances in technology, we are in the process of incorporating the different vein imaging tools we use to determine available access sites. And we're also going to consider the 5 categories that Dr. Shears presented in his presentation. Next slide. Patients with difficult IV access are frequently subjected to repeated attempts by multiple practitioners. These attempts may range from 1 to 10 or even more. This leads to increased pain and anxiety for the patient and their families and impacts patient satisfaction scores. A delay in establishing vascular access can also result in a delay in the administration of fluids and/or medication. With multiple attempts at attaining vascular access, the healthcare provider will become frustrated and will also become less productive because of the increased time it takes to establish access. In the 2014 INS position paper titled Recommendation for Improving Safety Practice with Short Peripheral Catheters, the INS statement of position is to incorporate vein visualization technology as a routine strategy for patients with difficult or poor venous access. Visualization technology can improve success rate, decrease unsuccessful insertion attempts, and improve patient satisfaction. Visualization and palpation are the techniques used in each of the tools that we use for determining right line and right person. As Dr. Shears demonstrated previously, being able to enhance our ability to visualize and assess veins with devices like transilluminators, near-infrared, and ultrasound will decrease the number of IV attempts made on patients with difficult venous access. Transillumination is one technology we use that can improve the visualization of non-palpable, non-visible veins in infants and children. The light is held adjacent to or under the patient's extremity. LED transillumination has been successful by focusing light through the tissue, but it has largely been limited to infants and small children as it tends not to penetrate through thicker tissue or be anatomically useful beyond the hands and feet. It can be used in premature infants along the extremity. The superficial veins absorb light and appear as dark lines against the surrounding illuminated tissue. Dimming the lights is required to improve vein visualization with this device. Our team has been using this for many years, but it does have its limitations. Next slide. Near-infrared vein visualization technology projects a near-infrared light which is absorbed by blood, reflected by surrounding tissue, and is projected in a digital real-time image on the patient's skin. This technology displays subcutaneous veins on the surface of the skin, allowing the clinician to perform vascular access with both hands and does not require a three-dimensional extrapolation. Our team uses near-infrared technology daily. We use it for vein mapping, assessing bifurcations, valves, and confirming refill rates of the vessels. We use these devices to determine site availability. It is especially helpful to be able to have that conversation with the provider to discuss alternative access for those patients that have no viable veins or difficult access. The use of near-infrared technology has decreased the calls I receive saying that the IV team has refused to stick. It gives us a complete vascular access picture to make the best decision for our patients. Near-infrared allows visualization up to 10 millimeter depth. It can and has converted our difficult vascular access patients to one of many options. A third of our vascular access team has less than a year experience as a vascular access consultant. Near-infrared has enabled them to improve their success rate and move closer to a one-stick per start rate. It has also provided the team with the ability to assess the patient's vascular access up front and develop a plan. Being able to plan and identify appropriate vasculature has raised the bar of our vascular access team's success. Ultrasound can provide excellent resolution of vessels and tissue, using high-frequency sound waves delivered through the transducer held on the skin and the image being observed on the screen. But it requires the user to hold the transducer with one hand, perform the vascular puncture with the other hand, and possess the skill to think three-dimensionally as one is looking for a two-dimensional image while attempting to place the needle in the center of the vessel. And add a moving patient to this, and it makes it even more challenging. The weight of the transducer may compress the more superficial vessels. There is also an added cost due to the use of gels, probe covers, and needle guide. Depending on the type of ultrasound used, deep veins can be visualized. The catheter length is the limiting factor for the vessels used. Approximately 15 millimeters is the depth we use as our guideline due to the amount of vein purchased for the catheter. The use of ultrasound has a large learning curve and requires not only advanced training, but regular use for the clinician to be proficient. Next slide, please. Patients with difficult to find veins remain a challenge. Failed insertion attempts will cause increase in stress of patients and families. It will cause decrease in patient satisfaction scores, which is factored into reimbursement. It causes increase in pain, causes delay in treatment, and multiple unsuccessful attempts make future attempts more difficult by damaging veins and causing vessels and tissue trauma. This can lead to the reduction of viable sites, stenosis, thrombosis, and extravasations. The increased cost can be significant. The increased cost was presented in our first webinar of this series. Failed insertion attempts also lead to CVC placement, which has additional complication risks. Pre-insertion assessment and utilizing imaging devices will minimize IV attempts and ensure patient safety and comfort. It will decrease first-time stick success rates, decrease failed insertion attempts, and improve patient satisfaction. Each technology has its own application and place in vascular access assessment. In closing, a comprehensive vascular access assessment to determine the optimal strategy prior to venipuncture or insertion of the venous access device is the most important tool for vein preservation. It is important to determine the right line, the right person, and the right technology to improve patient outcome, as well as the other rights that Dr. Scheer presented earlier. I want to thank you, everybody, for listening to our webinar, and we will now turn it over to questions.
Thank you. I would like to thank our presenters today for sharing their keen knowledge on the issues discussed, and we did get some questions typed into the chat section. This first question goes to Melissa. Melissa, when do you use NIR and when do you use ultrasound? So
here we start with, of course, the visualization, the palpation. We will use a transilluminator on our babies and looking for veins. Then we move to the near-infrared, and once we move to the near-infrared, we will map and look if we can't see the vessels, and then if there are really, if we've attempted some vessels and we can't, then we will move to ultrasound. So it's just really a process of starting with kind of the basics, if you will, the visualization and palpation, then we move to the transilluminator, the near, and the ultrasound.
Great, thank you. This next question goes to Dr. Scheers. It says, can you elaborate a bit about sticking under the light? We have looked at one of these systems, and some nurses think it would be distracting. Can you elaborate just a bit, Dr. Scheers?
Yes. Similar to some of the things that Melissa mentioned in her presentation, one of the many nice things about near-infrared is that your practice doesn't really have to change very much. The device has a there's a couple different versions. There's a small handheld version that can either, if you have a colleague that can hold it for you, or there's a nice gooseneck application that you can apply to a bed or IV pole or other, and to hold it in place as you're working. And then if you work on the edge of the projected rectangle, it doesn't really interfere at all with the normal process. The device is amazingly accurate, so the back projected vein that you see on the skin is exactly what is underneath the skin. The Christie folks have spent a lot of resources both getting that right and understanding their device, so that when you see the size of the vessel down on the skin, that's what it is. consequently you can trust that image. You just have to know to have it the right distance away from the skin so that the lettering is in good focus, which ends up being about 12 inches or so above the skin. And then you insert an IV just like you normally would. With the other exception, there's things I always do prior to insertion. I milk the vein so I know where are the valves, where are the tortuosities, etc. I line up the edge of the square projected, the rectangle projected down, so that when I'm doing a stick, the needle is going in just inside the edge, the proximal edge of that rectangle, so my hand doesn't get in the way of the back projection. And I stick directly down on the center of the vein. It's important that you don't chase after veins that are too small. So you look for that black area of vein, not the fuzzy edges part, but that black area. The black area, the solid black area, are definite vein lumens with concentrations of hemoglobin. When you get the fuzzy edges, it could be a very deep vein, and it may be under there, or it may not be. Those are veins that are a little bit less, or a little bit harder to know. And with experience, you'll be better able to distinguish those. A lot of the problems that patients have, or that clinicians have, is just there is a little bit of learning curve understanding the difference between good veins and bad veins. As long as you're going down directly on the center of the vein, you are going to be very happily surprised at how useful this is to you in your clinical practice. And it saves me just so much time and so many sticks for patients, even difficult access patients. It's just incredible.
Thank you. There's another question directed to Dr. Shears. It says, I work in a medical ICU, and it seems to me antibiotics are ordered more frequently because blood cultures are contaminated. How do you think these NIR devices can help minimize blood culture contamination during collection?
Yeah, that's a good question. The problem, of course, this is an age-old problem, and it's even more pertinent nowadays because positive cultures, whether they're false or not, may end up dinging us in terms of being called a CLABSI and reducing reimbursement. So you get the double pain. You're paying for antibiotics. You're having less reimbursement. It's all bad. So using near-infrared for drawing peripheral cultures is really nice because we've all been there. You prep the site. You think you start out, you palpate, you think you know where the vein is, then you prep the site, you put the needle in, and you can't find it for anything. And you're doing now the singer-sewing method, your needle's going all over the place, you're not hitting blood. Pretty soon you introduce your hand back into the scene, and then you end up contaminating things, and then you get a culture with gram negatives or whatever. Is it real? Is it not? So near-infrared can help you have a no subsequent palpation approach. You can see the vessel. It's really nice because you can watch the vessel the entire time as you're doing the stick. People have various levels of palpation skill. It's not some people, I don't know what it is. Maybe they have a higher density of receptors on their fingers or something. Some have just a great sense of it, others do not. With near-infrared, you see the entire, you see how the vein, the direction of the vein, where the fattest part is, so you can strategically position your needle so that you're more apt to get a full vial and not have to retouch the surface. So it's an aid for phlebotomy and a definite aid to help reduce contaminated blood cultures. The study's not been done yet, but it's a no-brainer. Once you understand this process, you'll say, oh yeah, I get it, and you'll start using it in that circumstance and have fewer positive false cultures.
Okay, thank you. And we have time for one other question. We had several others, but we'll direct the final question to Melissa. What is the size of your IV team?
The size of my IV team, I have an IV team and I have a PIC team. We have a total of 22 employees for both teams. There are 13 on the IV team and there are 9 on the PIC team. So usually the PIC team is the one that's called for the more difficult because they're experts on the use of ultrasound. The IV team has learned how to use ultrasound, but the IV team pretty much uses the near-infrared for their mapping and things like that.
Okay, thank you. In light of the time, you're able to get your CE credit by going to the link on the page that on the slide that is up. We do have a few other questions. If anyone would like to remain on the line, I will direct a couple of other questions. Otherwise, you're free to go. And we certainly thank you for your participation in today's webinar. And this next question goes to Dr. Shears. What is the best way to teach new nurses how to measure the diameter of vessel for proper catheter size? Do you have any thoughts on that?
Yeah, sure. So, for example, when using near-infrared, as I mentioned earlier, the back projection of the vein is what it is underneath the skin surface. So an easy thing to do is to, if you've already prepped the area, you can put your catheter right down, sort of superimposed on the vein. And, current thinking is that the catheter, the IV catheter, shouldn't be any larger than about 1/3 of the vessel size. And I think that makes good sense. So you can directly look at it and say, okay, the catheter looks to be too large for the vessel or just about right. So you're shooting for about 1/3 of the size, and because you can rely upon the back projected image of the vein, you can just lay it over that and make that determination or that approximation visually.
Okay, thank you. And we have one final question for Dr. Shears. We see many patients that are obese or are very edematous. Does NIR technology help to show veins in these types of patients?
Yes, as a matter of fact, very well. Near-infrared sees through fat quite nicely, and edema doesn't have any negative impact. The issues come more for if there is a lot of fibrous tissue, such as from a muscle tendon insertion or other, where there's a lot of reflection from that fascia. That scatters near-infrared light, and so it's difficult for the device to collect that and make sense of it. But for patients that are obese or patients that have edema because of a SIRS response or other, you can use near-infrared quite nicely and get good visualization of the subcutaneous area.
Okay, thank you. With that, we'll close our webinar today, and we appreciate your participation.